So welcome to another video with myself, Dr Iqbal Malik, cardiologist in London. This is a valve-in-valve TAVI, which of course can be straightforward or can be potentially fatal because of coronary occlusion. This is a 77-year-old gentleman with a tissue aortic valve, a pacemaker, and now breathlessness because of a re-narrowing and leak on that valve. He's awaiting a hip operation, some scalp surgery, and he's had a stroke in the past. So he's on clopidogrel for the stroke, on some blood pressure pills and a cholesterol tablet, and of course a prostate tablet for his age. He could have a redo operation with about a 3% mortality or a TAVI, but of course with redo surgery there's a risk of stroke and infection also. It's a perimount valve, so from the valve-in-valve app you can see the shape of it, a height of 16, an internal diameter of 21, and so when we do the CT scan we see that that is indeed accurate, and when we do the coronary heights, from the bottom of the frame, they're 14 and 15. But with a 16 valve, they're going to be pretty close to the top of the frame. The valve is aligned, the shape looks like the perimount valve, and the legs are pretty straight. So really a detailed CT analysis, and I've taken the time in 3 Mencio to line with the top of the valve, and then find the left coronary artery. And we can see the left coronary artery is about halfway through, so half is exposed, half is not exposed. We then find the post closest to the right coronary and do exactly the same thing, and we just rotate to the right coronary artery again. Half is exposed as half is not. So these coronaries could potentially be in jeopardy if we put the valve in and also stretch it. So that's worth paying attention to, certainly. So once we've done that detailed analysis, we know that we're worried about the coronaries, then it's a question of what we do about that, and this is where the thought process with a valve-in-valve TAVI occurs. So we've taken it to the MDT, and the final decision of the MDT is that we're actually going to do a valve-in-valve TAVI and then think about coronary protection. Of course, surgery is also possible. So what about the coronaries? Don't worry, it's fine, the VTC is good. Protect one, protect the other, protect both. My concern is how you might protect both, because I think we should protect both. There's a CHIMNEY stent, a BASILICA procedure, a unicorn procedure, or a LLAMACORN procedure. So here's a CHIMNEY stent. You take a guide catheter, you place a stent into the coronary, and if the coronary perfusion is reducing, you can place that stent. It's already there. I modified that by having a guide in guide, a stent, always using ultrasound and probably a double layer of stent and high pressure inflation. This is a BASILICA where we poke an electrified wire through the leaflet. We then tear the leaflet with a snare, and then we can put a valve in. Here's a unicorn procedure, a simplified BASILICA, one shot through. You create a balloon to create a space and then put a big valve in that tears the rest of the leaflet. And then the LLAMACORN, which is a modification of unicorn, where again poke a hole in the leaflet, enlarge more and more up to an 18 balloon, and then put a valve in. That leaflet tears in odd ways. My worry is that after we've modified with a 24 balloon, the VTC may change, and therefore you have to protect both coronary arteries. So my final choice was to protect with stents, hoping that actually we wouldn't need to put anything in, and also perhaps do an aortogram while the balloon's inflated. But of course, even if you've got a stent in properly, you can have delayed problems. There are 3 choices of valves. The Edwards, the Pro, is that you get the result you get. There's no expansion afterwards. You can modify the valve before and after, but you can't be repositioned, and it's a smaller valve because it's a valve inside a valve. The MEDTRONIC valve with the lowest profile is supraannular, but that may make the coronaries harder. The ABBOTT valve may provide the best. It's recapturable, it's got large cells for coronary access, it could be aligned. You get early pressure recovery, so you know if the coronaries are in jeopardy. So my final choice was to put the ABBOTT Navitor valve in a 25mm. So how are we going to do this? Well, we need 3 access points because I need to protect the left coronary, the right coronary, and also obviously get the valve in. So I've got right radial, I've got left femoral for the left coronary, and I've got the right femoral for the main access. So there we have the 3 accesses sorted out, ready to go for the procedure. This gentleman's wide awake, by the way. I always check that the punctures are clean. They were done with ultrasound. Here's the main access, and then here's the secondary access. So done under ultrasound, check on the angiogram pre-close. So glide sheath in the right radial, femoral access. Just to make it easy, right arm, right coronary, left leg, left coronary. So the coronaries looked fine, and I've protected using a guide catheter, a guide liner, and a stent inside the coronary sized to the proximal part of the vessel. We always do hemodynamics, and here's the initial one showing that there is a gradient, but I'm also focused on the coronary perfusion pressure, the aortic diastolic minus the EDP. So we're going to do a balloon valvuloplasty as our first move. This is just to show you how we do it. Then we've got a syringe and we've got an indiflator. We push hard with the syringe to fill the balloon, we turn the three-way tap, and then we push with the indiflator to try and crack the balloon. And so we can see that this is the balloon going up, and as it goes up, it's a 24 true balloon. It locks into position, we push hard, and I did do an aortogram, but I think the balloon is large enough to include the whole aorta, so I don't think the lack of perfusion in the coronaries told us very much. And I'm also not sure it actually cracked the valve. So this is just preparing the ABBOTT Navitor valve. We check outside the body, and this is a sheathless approach I've used. Slip into the vessel on a safari wire. It slipped in fairly easily. And then I've got to the LAO view, and I'm rotating to align one small disc internally, two discs on the outer curve. Then as I've pushed in, something interesting happens, and you have to look at where the right coronary artery is. The right coronary artery kit got wrapped around the safari wire, and so at this stage we've got no risk to the coronary, so I pulled the wire back, rewired, and then was able to get the valve into position. So we're watching both the right coronary artery and the left coronary artery guide catheters as we push through, and once we're in position, then the deployment of the Navitor valve is using that blue circle that we're now rotating. I've got a hold of the wire, I've got a hold of wire of the catheter to push back and forwards a little bit, and actually I used 120 beats per minute pacing just to stabilize that valve as it moved in and out. And this is a live true time picture of us deploying very slowly. Watch the pressure, because really most of the time there's no pressure drop, and just as the valve expands into position, we lock it into position, then the pressure dips a little bit, but only for a very short period of time, and then you can see the pressure is recovering already. So we've got to the lock, we've checked the coronaries, nothing's happened, and then we check in both views, is the height of the valve okay, and I think it is. And so it's not too high, not too low, and so here's us finishing the deployment. It pops out, there's still one cable caught, and here's the next pop as the last cable releases, and that produces a beautiful flower. We then take the nose cone out by pulling the wire back. We don't want to pull this valve out at the moment, and we've still got both coronaries protected. Coronary perfusion pressure is fine in both. And so are we done? Have we done enough? Well, not for a self-expanding valve. I'm going to check the hemodynamics, and the hemodynamics showed there was still a bit of a gradient, which is no surprise, but is a mean of 23 and a peak-to-peak of 14 good enough? I think not. And so we're going to do a further balloon inflation in a similar method to try and push the valve up. And you'll see that the posts of the old valve do push outwards as I inflate the 24mm balloon. And again, I'm not sure we've actually cracked the valve. We never saw that pressure drop even at 12 atmospheres, but we've pushed this Navitor valve up against the tissue valve as much as we possibly can. Now, an interesting thing happened. That balloon decided it didn't want to come out of the body once we'd inflated it. We'd used it twice. That's an 18 French sheath, and you do not want to tug at this stage. So what I decided to do was take the balloon up to the top, pull the safari wire out, and then use a safari wire as with its bend just to change the angle that it was pulling into the sheath in, and that worked, and everything came out. So we're checking the coronaries again, and you can see there's flow in both coronaries even after the second balloon inflation. And so I'm now comfortable that we're getting a good result. And actually the pressures, the hemodynamics after the second balloon inflation are better, with the mean and peak about 12 and coronary perfusion significantly elevated. And you can see that, and this is me removing the stent from the left coronary artery. So you can see the stent goes into the guide liner then pulls back. There's no danger. And I think we can still get coronary access because it's a large cell design, even though I think the alignment in this situation is incorrect. So I think we're non-aligned because I was focused more on the coronaries and the true alignment here, and another use for the large cell design, so the alignment's not absolutely essential. So we've got a good result, I think. A final leg shot, we've got no damage to that artery, and I think we can say with a sigh of relief that although we were predicting trouble, actually there was no trouble at all, and this gentleman went home the following day. So jeopardy avoided by having a detailed strategy. He was awake and heard all our discussions, was quite amused by it, and it's better to be safe than sorry. So I would look forward to seeing you next time for another case.